for that joint motion, but oftentimes, yeah, so you can see that little bit of joint motion. If I come over here, I'm blocking scapula, I'm coming over here on glenoid, and I'm just motioning it, that A to P. What we'll see oftentimes, I've had several times with a patient that has a lot of pain in the shoulder, and I just go to do that little squeeze, and you can actually feel the head of the humerus just like suck back into the middle of the glenoid, and then all of a sudden you recheck range of motion and it's immediately better. Now that's not going to be a quick fix for everything. Now we may need to stabilize that person, work on some postural issues. I may need to tape their shoulder in a position that doesn't allow it to continue to, in this case, essentially, truly sublux, anteriorward. But it's just a cool little screen. I don't know where I picked that up along the way, but I ended up just kind of using it on most of my patients. And sometimes when we're doing just a little bit of an assessment, that assessment ends up being somewhat of the treatment. We'll do the same thing when we're doing meniscal tests later on. You probably know McMurray's test. McMurray test, oftentimes what we're trying to do is we're trying to find if there's some type of meniscal entrapment from a tear. And sometimes just going through the maneuver of McMurray's test, you'll free that entrapment, and that patient's like, oh, my knee's so much better. Yeah, for now. Yeah, it's great for now. But you have that tear in there. But that's indicative that we had a positive finding, and likely you're going to have issues down the road. But sometimes that can sort of be the treatment of that day as well. So, all right. So that's that maneuver. You guys can play with that a little bit after a while. But let's go all the way back and let's go ahead and practice our